All right, well, welcome back for Lab 7. So we've got 6 of them down, 2 to go, almost there. So this lab is going to be a little bit different than previous labs in that in the past we've done the bones one week and then muscles the next week. This one we're going to do them all together. We're going to cover the lower leg. The good news is though that we're only going to cover the extrinsic muscles of the foot. And so it's the same concept as we talked about with the hand and wrist. Extrinsic in the case of muscles in the lower leg and foot, or extrinsic in the case of muscles of the forearm and hand, means that the muscle originates outside of the foot or outside of the hand. So in this case, the muscle originates in the lower leg and then it inserts somewhere in the foot. So there's only 12 muscles that we're going to cover, so not a ton. So that's how we're able to do both bones and muscles this week. So hopefully you've got the lab sheet in front of you. So one of the things you'll see there is we're going to start with the tibia. The lower leg has 2 bones, and I've isolated the tibia in this view. So those 2 bones are obviously the tibia, which is the shin bone. It's the larger of the 2. It's the weight-bearing bone. And it's also the medial of the 2. So that's an important thing to know, is that the tibia is on the inside of your lower leg, and then the other bone is the fibula. So the fibula is thinner, and it's on the lateral aspect. So we're going to start with the tibia, the primary bone of the lower leg. And so what you're seeing here is the tibia of the right leg, because everything I'm going to do is going to be on the right side of the body. So this is a right tibia. So what you're looking at then in the case of the right tibia is that, in terms of the first landmark, so we've got our medial condyle. So you'll notice here that there's, remember we talked about with the femur, there was a medial and lateral condyle that articulate with the medial and lateral condyles of the tibia. So now we're getting to those. So the medial condyle of the tibia is all of this. And it includes, if you kind of make a C shape with your finger and you wrap it around the physical bone, all of that on the medial aspect of the bone is going to be the medial condyle. Then the lateral condyle obviously is the one over here. So all of this is the lateral condyle. And if we go to more of a 3/4 view that you can see here, so again, this is going to be our medial condyle, the larger of the 2, because the medial condyle of the femur is the larger of the 2. You'll see that there's an articular surface here. So that's, again, lined with hyaline cartilage. So that's the medial articular surface, and then we've got a lateral articular surface over here atop the lateral condyle. Between those two, so between the medial and lateral articular surfaces, we have the intercondylar eminence. So when you get to lab and you see the actual physical bone, there's an obvious ridge between those 2 articular surfaces. And so then that obvious ridge is the intercondylar eminence. And so the name tells you what it is, right? So it's intercondylar, it's between the condyles, and an eminence is sort of a raised area. So the ACL and the PCL are going to insert anterior and posterior to that. So the ACL is going to insert kind of over in this region, so anteromedially, and then the PCL is going to insert back here. So that's the significance of the intercondylar eminence. Then if we go back to just a straight anterior view, we've got the tibial tuberosity. So the tibial tuberosity is this thing. It's a pretty obvious knob that most people have on the anterior aspect of their shin. So the tibial tuberosity is this really, it's about the size of a quarter. Again, a raised area there on the anterior surface of the tibia. So the muscle group that inserts there is the quadriceps group. So that's what makes that landmark significant, is that the quadriceps group that includes rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius, all 4 of those muscles insert there via the patellar tendon. We've also talked about that landmark in class when we talked about Osgood-Schlatters disease, which is where people, basically adolescents, sometimes will get a raised area there where the quads start to pull away from their insertion at the tibial tuberosity. And so, again, that's what that is. Gerdes tubercle is a little bit harder to envision. So Gerdes tubercle is where the IT band inserts. So Gerdes tubercle is kind of over in here, and this will actually probably be easier to show you in lab this week, because you can see on the skeletons where they've got the origin insertion, Gerdes tubercle is a pretty obvious little blue splotch right there. But basically, Gerdes tubercle is on the lateral condyle, and it is just inferior to that articular surface. And so the thing I want you to know about Gerdes tubercle is that that's where the iliotibial band or the IT band inserts. So then in a way, that's the insertion of the TFL muscle and also part of gluteus maximus. Because remember, glute max and TFL both insert into the IT band. And so via Gerdes Tubercle, or via the IT band, they insert into Gerdes Tubercle. Now that said, glute max does have a separate insertion, so it actually has two insertions. The other one is into the gluteal tuberosity. Okay, similar concept on the medial aspect. We've got the area of the pes anserine. So the area of the pes anserine, the way you find it is you go to the tibial tuberosity here, and then go just inferiorly and medially, so down here. All right. So once we've done that, it's not a very obvious area. There's no like ridge or any sort of distinguishing characteristics, but the area of the pes anserine is the site of insertion of three muscles. So those three muscles are sartorius, gracilis, and semitendinosus. So all three of those insert there the pes anserine. The way I was taught to remember it back when I took a class like this was say grace before T. I don't know if that helps you at all. But so that mnemonic is sartorius, gracilis, and the T is semitendinosus. So one of the medial hamstring muscles inserts there. There's also a bursa there, can sometimes get inflamed with repetitive knee flexion and internal rotation. All right, so that's all the stuff on the proximal aspect of the bone. So now we're going to go down to the distal aspect of the bone down here, and the next landmark is the medial malleolus. So that is this medial projection of the bone there. Oftentimes people will refer to that as something like their inside ankle bone. So it's this really obvious knob on the inside of your ankle. That is your medial malleolus. So it's pretty easy to find. It's a really obvious landmark. Then we're going to go from the medial malleolus, which obviously is on the medial aspect of the bone, we're going to go over to the lateral aspect of the bone. And I'm going to switch views to go to a lateral view. So there's a medial view. There's our lateral view. So now you're looking at the bone obviously from the lateral aspect. So you've got a fibular notch. So again, the tibia is the medial bone, the fibula is the lateral bone. And what that means then is on the lateral aspect of the tibia, you're going to have landmarks that clear space for the fibula. So this little landmark here, this little articular surface, the fibular head is going to articulate with that. But right now we're talking about the fibular notch, which is down here on the distal aspect. And so you can see that articular surface there, that hyaline cartilage. So that's the fibular notch. So it's a little indentation on the lateral aspect of the tibia, distally, where the fibula is going to sit up against it and help form what's referred to as the ankle mortise. And so the ankle mortise is the combination of the fibula, more specifically the lateral malleolus of the fibula, the distal aspect of the tibia, and the medial malleolus that sort of forms the socket into which your talus, one of the tarsal bones, fits. And speaking of the inferior aspect of the tibia, our last landmark on the tibia is now we're looking at the bottom of the tibia. That's your inferior articular surface. So same view again, the right tibia. This is the medial aspect over here on the right side of your screen. So this is the inferior articular surface. And again, the talus, T-A-L-U-S, one of the tarsal bones is going to interact with that articular surface to help form one of the two primary ankle joints, which is called the Taillow joint. So then the only other thing we need to know about the tibia is how to find right and left. So to find right and left, you really have to know two things. The first thing is you have to know which side is the front of the bone, or the anterior aspect. Then you got to know which side is the medial or lateral aspect of the bone. So the way I would do it with the tibia is to find the tibial tuberosity. Again, this landmark right here. Obviously that has to go in the front. So that's the anterior aspect of the bone. And then for medial lateral, I would use the medial malleolus. So you can see down here, there's your medial malleolus. So if we put the medial aspect, if we put the medial malleolus medially, tibial tuberosity anteriorly, then we know that in this case we have a right. So I would use those two landmarks to do right and left. So that's it for the tibia. So now we're going to move on to the fibula, so the lateral ankle bone. So again, there's your fibula. So I've isolated it. Again, it's a right side. So a right fibula viewed from the front or from the anterior aspect. There's only 4 landmarks I want you to know on the fibula, and really the hardest thing about it is doing right and left. I think of the bones that we cover, right and left in the fibula is probably the most difficult. So again, you're looking at the right fibula from the front, or an anterior view of the right fibula. So the first landmark on there is the apex. So the apex, the apex is this little projection right off of the head of the fibula. So this big rounded end here, that's the head of the fibula, and then the little point or projection from the top of the head is the apex. And so it becomes a little more obvious. That's a medial view. There's our lateral view. So now you're looking at a lateral view of the right fibula. So again, all of this rounded area here is the head, and then the point that comes off of the head is the apex. And then obviously anytime we've got a head, we've got a neck. So then the neck is this narrow area just below the head. And so those are the only three landmarks you need to know for the proximal aspect of the fibula. And then on the distal aspect, you only got to know one, which is the lateral malleolus. So all of this down here is the lateral malleolus. So again, people typically refer to that as something to the effect of your outside ankle bone, right? So if you look at the lateral aspect of your ankle, there's a really obvious knob out there. That is the lateral malleolus, basically the distal aspect of the fibula. So how do you do right and left in the fibula? So one of the things that makes the fibula kind of tough, actually is top and bottom, is somewhat difficult too. So the proximal aspect of the fibula, so both ends have kind of a rounded aspect to them, but one of the things that you'll see is that the fibular head is much rounder medial to lateral. So if I switch views and go with this anterior view, you'll notice that the fibular head fairly round up here, as opposed to the lateral malleolus, one side of it's flat, because that area has to fit up against the tibia. So where you've got one side that's flat, that's going to be the distal aspect, or the inferior aspect of the fibula. So, and again, you can see that articular surface on essential anatomy. It's not quite as obvious when we get to the plastic bones in the lab, but that's the articular surface that's going to interact with the tibia. So in terms of how do we know medial lateral? Well, to do medial lateral, what I would do is, so you find this flat surface, that's obviously going to go on the medial aspect because that's going to interact with the tibia. And then you'll notice that it bulges out here for the lateral malleolus. So that's how I do, make that face laterally, make the flat area face medially. And then if we look at it from the lateral aspect, so again, that's medial, there's our lateral. So this is the anterior aspect of the bone right here, so this is the front of the bone. So if you look at it closely, and it's not quite as easy to tell here, but if you look at it closely in lab, you'll notice that the posterior aspect of the fibula is relatively straight up and down here, and then the anterior aspect kind of bulges out, sort of looks like a beer belly, if you will, or pregnant belly, whatever works for you. And so that aspect, that more beer belly aspect, needs to go toward the front. So if I put the flat surface on the lateral aspect medially, and then if I put this rounded area here, this little beer belly area, toward the front, then I know that in this case, this is a right. Now, that probably isn't going to make a whole lot of sense until you have the actual bone in your hand, so we'll go over that in a little bit more detail in lab this week. So those are the landmarks of the fibula, and then we're going to move on to the bones of the foot. So the way the foot bones work, the way I've laid them out on the sheet, so there's two of them at the very bottom of the first page. So you'll see there that it says tarsal bones. So the tarsal bones are 7 sort of oddly shaped bones on the posterior aspect of the foot. So on this, what you're looking at here, again, this is the right side. So this is the right foot viewed from the top, so it's a superior view. So the tarsal bones include these 3, which are the cuneiforms, and then this one, which is the cuboid, navicular, talus, and calcaneus. So the tarsal bones are all of these, again, sort of oddly shaped bones on the posterior aspect of the foot. They're analogous to the carpal bones in the wrist. So remember the carpal bones, you had 8 little short chunky bones in the wrist, same concept in the foot. They're larger, obviously, but the same concept. And so now instead of 8, we just have 7. So those are our tarsal bones. So we'll start on the posterior aspect of the foot. So we'll start toward the back, and we'll start with the calcaneus. So the calcaneus is your heel bone. And you can see it back here. So this is the calcaneus back here. Or if we switch views, So now you're looking at a lateral view of the right foot. So all of this is the calcaneus. You don't have to know any landmarks on it. This will work just like we did with the carpal bone. So all you got to do is be able to pick out if there's a sticker on that. That's the calcaneus, or got my mouse back, or that's the cuboid or talus or whatever. So these are just like the carpal bones, again, all or nothing. So you either know that's the calcaneus or you don't. So the calcaneus, again, is your heel bone, so it's there. It does have some pretty obvious features that'll become important when you do more advanced anatomy. So there's the dome back here, your Achilles inserts into that. There are medial and lateral tuberosities. And so you'll get, like the plantar fascia originates from the medial one, but you'll get into that in later classes. All right, so there's a calcaneus. On top of, or proximal to the calcaneus, is our talus. So this bone up here is the talus. So if we go back to the superior view, the talus is the one that's the most prominent. So all of this is the talus. And so the talus, the most obvious landmark on it is the talar dome. Again, you don't need to know landmarks, but it is going to be relevant here in a second. So this is the talar dome. So that will interact with the inferior articular surface of the tibia. And so that's going to form one of the two primary ankle joints, which is your tallocrural joint. Other aspects of the talus include the neck. So it's kind of this narrow area here. And then we've got the head right here, which is going to interact with the next bone, which is your navicular, which I didn't check the sheet. Hopefully that is the next bone. Hold on, let me turn pages. And of course I skipped one. So anyway, that's okay. We'll jump around a little bit. So this is the navicular here. Again, you see that the boat theme is pretty common in anatomy. And so again, navicular comes from the Latin word navis, and so that's where we get navy from. So this one is, if you view it in isolation, it kind of has a boat shape to it. So that's your navicular of your foot. It does have an important landmark over here. You don't need to know it, but there's a pretty obvious projection over here called the navicular tuberosity. And the reason that becomes important is if we're looking at the alignment of somebody's foot and we want to see if they have high arches or flat feet, we'll use this landmark to help us determine that. So navicular is here, interacts with the talus. Then over here on the lateral aspect, we have the cuboid. So the cuboid is kind of like the hamate in the hand. Remember that the hamate interacted with the fourth and fifth metacarpals. Same concept here in the foot, except the cuboid, or in that the cuboid articulates with the fourth and the fifth metatarsals. So same idea, it articulates with the lateral two, or the last two metatarsals in this case. Then we've got cuneiforms. There's 3 of them. And so the cuneiforms interact primarily with the navicular. So again, navicular is here. So we've got a medial cuneiform right there. We have an intermediate or middle cuneiform right there. And then we have a lateral cuneiform, or the lateral cuneiform right there. So the cuneiform's then medial here, because this is your big toe. So the medial cuneiform's there. Middle or intermediate, and then the lateral cuneiform is there. So those are our tarsal bones. Then we've got our metatarsals, which are these guys. So the metatarsals are the long bones of the foot, very similar to the metacarpals, which were the long bones in the hand. Same idea and same basic structure. So you've got metatarsal heads, necks, and bases. Again, those are landmarks you don't need to know, but the way that that works, because that does become important here on the lateral aspect of the foot. So the metatarsals, the way the numbering works is that you've got number 1 is your big toe. So you can see it's the shortest and thickest of the metatarsals. Number 2 is there, 3, 4, and then 5. So the bases of the metatarsals are proximal. The heads are distal. So when you stand on your tippy toes, you're standing on the heads of your metatarsals. So the reason I mentioned the base of the fifth is a pretty important landmark is because one of your peroneal muscles, Peroneus brevis, inserts there. And if you really sprain your ankle significantly, so if you get a really severe ankle sprain, one of the things that can happen is that tendon can pull away from the base of the fifth here, and you can get a little fracture through here, which is called a Jones fracture, which is a fairly common injury in athletes who sprain their ankles. So those are the metatarsals, again, 1 through 5. 1 is the big toe, 5 is your pinky toe. And then same concept as we talked about in the hand with our phalanges. So remember, the phalanges in the hand are the finger bones, and the foot, they're the toe bones. So you have the proximal phalanx of the first toe here, distal phalanx of the first toe here. Remember, the big toe is like your thumb, so it only has 2. Then on digits 2 through 5, so from your second toe on out to your pinky toe, we've got 3 phalanges. So there is, just like in the fingers, there's a proximal phalanx, a middle phalanx, and then a distal phalanx. So proximal, middle, and distal. And so those are the phalanges. All right, so the next thing on that sheet is joints. So the first joint on there is the taloacrual joint. So there's a lateral view of the foot, medial view of the foot. There we go. So now you're looking at the right ankle from the anterior aspect. So the taloacrual joint, there are 3 bones that articulate, and those bones are the tibia, so again the largest bone in your shin, the fibula, and the talus. So tibia, fibula, talus are the bones that articulate to make up the taloacrual joint. So there's 2 actions that we get at the taloacrual joint, and those actions are plantar flexion, and so it's spelled Plantar, plantar flexion, and then dorsiflexion. So dorsiflexion is dorsiflexion. So sort of an oddball thing. Plantar flexion is 2 words. Dorsiflexion is 1 word. I don't know why that is, but that's how it works. So plantar flexion is when you come up on your tiptoes. So if you're trying to look taller, or you're in kind of deep water or whatever, you're up on your tippy toes, that's plantar flexion. And then dorsiflexion is just the opposite. So if you take the top of your foot, bring it back toward your shin, so you kind of do like a calf stretch, that motion is called dorsiflexion. So both plantar flexion, when you push off, and dorsiflexion, when you bring your foot toward your head, those both occur at the taloacrual joint. So in terms of the plane and axis there, that's going to be sagittal plane and then x-axis for those. Then we've got our subtalar joint. So for the subtalar joint, I'm going to show you a lateral view of the foot. And so the subtalar joint describes the interaction between the talus and the calcaneus. So talus here, calcaneus here, and you can see this little joint that I'm tracing with the mouse. So that is your subtalar joint, and that is a surprisingly important little joint. So what happens there, there's 2 motions, and those 2 motions are inversion, eversion. So inversion is what we do when we roll your ankle. So if you take the bottom of your foot, or the plantar aspect of your foot, roll it toward the midline, that's inversion. And then eversion is the opposite. So take the bottom of your foot, roll it away from the midline, and that's eversion. So both of those 2 occur on every step that you take if your subtalar joint is functioning normally. So basically what ends up happening is when you first hit the ground, the first thing that makes contact when you're walking, and for most people when they're running, is your heel. And so when your heel hits the ground, it's going to be an inversion. And then as you go and if you move from, that's called heel strike, to now you step over the top of your foot and all of your weight's over that one foot, your calcaneus is actually going to slide from inversion to eversion. And so basically what that does is it unlocks the foot. So when your calcaneus is inverted, it pushes all those tarsal bones and metatarsals closer together, and so the foot is this nice rigid lever, it's locked, and then as we go to put our weight over the top of our foot, that calcaneus slides from that locked position from inversion, slides laterally into eversion. That basically unlocks the foot and allows those tarsal bones to slide apart, and so that helps us distribute weight across the connective tissue of the foot, including our plantar fascia, which is a band of connective tissue that runs from the calcaneus out to the toes. So subtalar joint then, inversion, eversion. You don't have to know plane and axis there because there actually isn't a true plane and axis. Probably should fix the lab sheet. So don't worry about plane and axis for the subtalar joint. Just know that inversion, eversion occur there. So now let's talk about the ligaments. So again, these would be in the question bank for the 3rd test in Canvas. You won't need to know these for the last lab quiz. So now what you're looking at the lateral aspect of the right ankle, but I just added the connective tissue. So there are 3 primary ligaments on the lateral aspect of the ankle that limit inversion. So those ligaments are And the first one, actually probably should have rotated the foot a little bit more, but it's hard to get all three in the same shot. So the first one's called the anterior talofibular ligament, and it's this little ligament right here that is on the, obviously, the anterior aspect of the ankle. So the abbreviation for that is ATFL. So again, it stands for anterior, so in the front, Taillow, so from the talus, fibular ligament. So anterior talofibular ligament, or ATFL, sits right there. And then the next one is the calcaneofibular ligament, which is here, or CFL, so calcaneofibular. And then we have the posterior talofibular ligament, or PTFL, back here. And so essentially, if you look at the lateral ankle kind of like a clock face, so the old analog clocks, the ATFL sits at about 3 o'clock, the CFL sits at about 6:30 or 7, and then the PTFL sits somewhere around, give or take, 9. So you don't need to know motions limited by those specifically, because basically they all limit inversion to some extent. And then the ATFL limits anterior translation of the talus, so keeps your talus from sliding forward. The PTFL limits posterior translation of the talus, keeps it from sliding backwards. But basically those are the ligaments that you sprain if you have sprained your ankle with your normal inversion mechanism. So if you rolled your ankle and you sprained it, you probably damaged, depending on the severity of the injury, you damaged at least the ATFL. And then with a more severe injury, so when people like hear and feel a pop and they get lots of swelling and bruising and they can't put weight on their ankle and it's kind of out of commission for a week, that's probably more like a grade 2. So with a grade 2, you've ruptured the ATFL, and then you stretched the CFL, and then grade 3, rupture ATFL, rupture CFL, and then you also stretched out the PTFL. So that's the way that those work. Then we'll look at the medial aspect of the ankle. So on the medial aspect of the ankle, you have what's referred to as the deltoid ligament complex. So it's called the deltoid ligament because the four ligaments together sort of make a triangle shape, and the Greek letter delta is a triangle shape. So if we look at the four of them together, it's kind of a triangle. And so that's our deltoid ligament complex. So the deltoid ligament complex is pretty similar to the complex on the lateral aspect of the ankle. So there is an anterior tibiotalar, a posterior tibiotalar, and then there's a tibio-navicular, and then a tibiocalcaneal. So that anterior tibiotalar is up here. Again, it's if I'd rotated a little bit more on that anterior view, you'd be able to see it, but it's right there. And then we have our tibio-navicular, which is right here, because again, this is your navicular. So tibio-navicular, tibiocalcaneal is right there, and then our posterior tibiotalar is back here. So those are the four of the medial ankle complex. Again, that's the deltoid ligament. And so the primary motion limited by all four of them is eversion of the foot, keep the foot from being pulled away from the midline. So sometimes if you get a medial ankle sprain or an eversion ankle sprain, which is fairly uncommon, but if you get that, that's damage to the medial ankle complex. So usually to get that injury, somebody has to kind of fall on the outside of your foot or forcibly roll it away from the midline. That's how we get an injury there. All right, so then we got two more joints, or two more sets of joints to talk about. So I'm going to go back to the view of the right foot from the top. So the first joint on there is the metatarsophalangeal joint, or MTP joint. So the metatarsophalangeal joint, so if this is our first metatarsal, this is the proximal phalanx. So the metatarsophalangeal joint is the interaction right here between those two. So first MTP joint is here, second is here, third, fourth, and fifth. You've probably heard about an injury to the metatarsophalangeal joint. So for example, in the 2019 football season for the Packers, one of the wide receivers, Devontae Adams, had a turf toe injury, and he was out for several games with that. And so what turf toe is an injury to the first metatarsophalangeal joint, so to this joint right here. And basically what ends up happening is you hyperextend it, so you push your big toe up toward your head, and you damage the connective tissue or the joint capsule on the underside of that, or on the plantar aspect of that joint. Stretch it out, you've probably torn some of it, and so basically every time you go to push off to propel yourself into the next step, it's going to hurt. It's a pretty sharp stabbing pain on the underside of the big toe. And so it's a surprisingly disabling injury, because people oftentimes are like, oh, it's a toe injury, what's the big deal? But again, if the way that we walk, we typically, the reason your big toe is larger is it helps you push off, helps push you into the next step. So you actually flex it a little bit, you bend it a little bit every step that you take. And so if you've damaged the underside or the plantar aspect of that joint, well, it's going to hurt every time you take a step. So that's the MTP joints. And then you have the interphalangeal joints, or the IP joints. So the IP joints, so again, the big toe only has 2 phalanges, so there's only one interphalangeal joint, which is right here. So that's the IP joint of the first. And then just like with the fingers, we've got the proximal interphalangeal joint here, and then the distal interphalangeal joint, or DIP, here. So PIP, DIP, just like with the digits. All right, so that's it as far as the bones and bony landmarks. So then on to the muscles. And again, there's only 12, so it's not as bad as it seems like it could be. So in terms of the muscles, the way that they're grouped, if you looked at the slideshow, is I have them by compartments. And so in the lower leg, you have 4 compartments. And what a compartment is a group of muscles, arteries, nerves, and veins bound off so separated, if you will, by bones and or connective tissue. So in the anterior compartment, you've got 4 muscles that are separated from the rest of the muscles of the lower leg by the tibia and fibula and the interosseous membrane posteriorly, and then by a band of fascia or connective tissue anteriorly. So again, grouped by compartments, basically you've got 4 muscles in the anterior compartment, 2 in the lateral, and then posteriorly you've got 2 compartments. You've got the posterior superficial, there's 3 muscles in that, and then the posterior deep, and then there's 3 more muscles in that. So starting with the anterior compartment, so the front of the lower leg, you've got the tibialis anterior. You can see it highlighted there. So the tibialis anterior is the muscle that we talked about when we discussed shin splints. Again, shin splints, if you look at the textbook discussion of them, it's typically a different muscle. It's tibialis posterior. But oftentimes when people come in complaining of shin splints, it's anterior shin pain. And so the muscle affected oftentimes is actually tibialis anterior. So the origin of tibialis anterior is the upper half of the tibial shaft in the interosseous membrane. And then from the belly, you can see this tendon that actually wraps medially and up underneath the foot. So it actually inserts on the plantar aspect of the foot. And more specifically, it inserts onto the inferomedial cuneiform. So the inferior aspect, the bottom of the medial cuneiform, and then the base of the first metatarsal. So again, that proximal aspect of the first metatarsal. So tibialis anterior has 2 actions: dorsiflexion, so picture foot up, and then inversion, so it brings the bottom of the foot toward the midline. So dorsiflexion, inversion are the 2 actions for tibialis anterior. The other thing you'll see on the slideshow is that it says holds up MLA. MLA is your medial longitudinal arch. So if I click back a little bit and look at the medial view of the foot, your medial longitudinal arch of the foot is the one that people refer to when they say that they have high arches or flat feet or whatever. There's actually 4 arches to the foot, but the one that people are most familiar with is this medial longitudinal arch that runs from the head of the first metatarsal all the way out to the medial aspect of the calcaneus. So all of that is your medial longitudinal arch, and so tibialis anterior plays an important role in holding that up. Then we've got our extensor hallucis longus. So anything hallucis or hallucis, however you want to say it, is something that deals with the big toe. So the big toe, another thing you'll see for that is hallux. So for example, a bunion is called hallux valgus. So the big toe is angled laterally. So extensor hallucis then is a muscle that extends the big toe. So you can see the origin there is the middle half of the anterior tibial shaft, and the insertion is the base of the distal phalanx of the first toe. So again, the big toe. And then the actions, it has 2. So it's going to, actually 3, I lied. So it's going to be a dorsiflexor and an inverter, and then it's also going to be an extensor of the big toe. So it does the same, 2 of the same things that the tibialis anterior does, dorsiflexion, inversion, but in addition to that, it also extends the big toe. Then we move on to our extensor digitorum. So this one works just like we saw in the hand, because remember that one had 1 belly and the tendon split into 4 to extend digits 2 through 5. Same concept in the foot. So you can see where the tendon splits here into 4, goes to the 2nd toe, 3rd toe, 4th toe, 5th toe. and then its belly is right here. So that's your extensor digitorum. So it originates from the upper 2/3 of the anterior fibula and their interosseous membrane, which is a band of connective tissue between the tibia and the fibula, and then inserts onto or into the extensor expansion of digits 2 through 5. So inserts into the extensor expansion of digits 2 through 5. The extensor expansion, you'll see there's, I don't think it's on the plastic feet in lab, but there's kind of a little diamond shape on the back of the IP joints. That's the extensor expansion. And so what extensor digitorum longus does then is it extends toes 2 through 5, and then it's also a dorsiflexor of the foot. Picture foot up. Then the last muscle in the anterior compartment is our Peroneus Tercius, or as you can see, so different fibularis and peroneus mean the same thing. They both deal with the fibula. So the textbook refers to these next 3 muscles as Peroneus Tercius, Longus, and Brevis. The anatomy app refers to them as fibularis. So either way, if you want to call them Fibularis Tercius or Peroneus Tercius, either one is correct. I learned them as Peroneus, so that's going to be the primary terminology that I use. But if you see fibularis, it means the same thing. So Peroneus Tercius originates from the bottom quarter of the anterior shaft of the fibula. So you can see it originating sort of from that front or anterior aspect of the fibula there. Pretty small little belly, and its tendon is right here, and it inserts into the base of the 5th metatarsal. So its action is dorsiflexion, or actions are dorsiflexion and eversion. So pulls the foot away from the midline. So one of the things to know is that of the 12 muscles, the 4 in the anterior compartment are dorsiflexors, and all the other 8 are going to be plantar flexors. So only the 4 in the anterior compartment are dorsiflexors. Everything else is going to be plantar flexor. And then they do other things, inversion, eversion, toe flexion, etc. But at the very least, anterior compartment muscles, dorsiflex, everything else, plantar flexes. The other thing about Peroneus Tercius is that on the plastic legs, the little tendon is on there. So basically you'll see this one extra tendon, but that's it, and there's no number on it. So you won't be able to find a number for Peroneus Tercius on the plastic leg, but its little tendon is on there. And so the easiest way to find it is to find extensor digitorum, and you'll find again that its tendon splits into 4. And then once you find the tendon that runs to the pinky toe, find that one additional tendon that runs almost straight up and down, and that's your Peroneus Tercius. So again, no number, but it is on there. So those are all the anterior compartment muscles. So now we're going to move on to the lateral compartment. And there's 2 more peroneal muscles there, or fibularis muscles if you want to go that route. So there's Peroneus Longus. So Peroneus Longus is the one that's highlighted there. So its origin is the head and upper 2/3 of the lateral shaft of the fibula. So it rises from the fibular head, but then basically the upper 2/3 of it. And then its insertion, it actually runs up underneath the foot. So it's going to run behind the lateral malleolus, behind or sort of alongside the cuboid, underneath the foot, and it's going to insert on the plantar aspect of the base of the first metatarsal and the medial cuneiform. So Peroneus Longus actually has the same bones of insertion as Tibialis Anterior, if that helps you out. So the actions there for Peroneus Longus is plantar flexion and then eversion. So plantar flexion, eversion for Peroneus Longus. And then Peroneus Brevis. So if something is brevis, it's short. So you can see Peroneus Brevis there, shorter than Longus. So Peroneus Brevis, the origin is the lower 2/3 of the lateral shaft of the fibula, and then it inserts onto the base of the 5th metatarsal. So again, that's one where if you really sprain your ankle pretty significantly, sometimes grade 2 sprain, you can pull this tendon, the Peroneus Brevis tendon, away from the base of the 5th, and that'll cause a fracture there on the base of the 5th, which is known as a Jones fracture. The other thing I'd point out is if you've sprained your ankle before, so you get damage to Peroneus Longus, Peroneus Brevis, and then Peroneus Tercius over here, at least one of the 3, if not all of them. And so you get some damage to the muscle spindles. Those muscles then are, they have basically a lag when the foot gets moved into inversion. So let's say you step off a curb wrong or something like that, and you start to invert the ankle. If you've sprained that ankle before, you get a delay in the sensitivity related to the muscle spindles of Peroneus longus and brevis. So basically it takes longer for them to contract and evert the foot and put it back in a good position, so you're more likely to sprain your ankle again. So those are the two lateral compartment muscles then, Peroneus longus, Peroneus brevis. So now we're going to move on to the posterior superficial compartment. So you got three muscles there. So you've got gastrocnemius is our first one. Gastroc we talked about with the knee. So the way that the anatomy app works, you have to highlight the heads separately. So here's gastroc, the medial head, then obviously there's a lateral head. Those two come together and insert via the Achilles tendon into the calcaneus. So the specific origins there, so again, two heads. So the origin of the medial head is above or proximal to the medial condyle of the femur. The origin of the lateral head is proximal to the lateral condyle of the femur. Again, both those two heads come together via the Achilles and insert into the calcaneus, which is your heel bone. So gastroc is a really powerful plantar flexor. So it brings you up on your toes or helps you push off. And then it's also, as we talked about, a knee flexor. So when we say plantar flexion, remember that the joint for plantar flexion is the Taillow joint. So it's a plantar flexor, Taillow. The other thing about gastroc is gastroc has a pretty high percentage of type 1 fibers, so slow twitch fibers, but it has more type 2 fibers than what we're going to see in one of the muscles we'll talk about here in a second, which is your soleus. So that's actually the next muscle. So soleus is there. So soleus is actually deep to gastroc. So what we had to do to get to this picture was take off the gastroc. So we've removed it. Now we're looking deeper. So that's your soleus. It's named that because somebody thought it was shaped like a fish. That's what the name means. So soleus is one that does not cross the knee. So whereas gastroc crosses the knee, soleus does not. And so you can see that from the origin where it originates from the upper third of the tibia and the fibula. And then it's also going to insert into the calcaneus, so into your heel bone via the Achilles tendon. So your gastroc and your soleus, they run together, have a common tendon of insertion into the calcaneus. So soleus is a postural muscle. So again, it is a really high percentage. I feel like it's like 80%. That may not be exactly right, but it's a really high percentage of type 1 fibers in almost everybody. So lots of slow twitch fibers. So that's the muscle that you use while you're just standing up, keeps you from falling over. It needs to be highly fatigue resistant. So from a strength and conditioning standpoint, sometimes people talk about trying to get bigger calves, and so why can't I get bigger calves? In part, it's because of the high proportion of your type 1 fibers in both of your calf muscles, both the primary calf muscles. So type 1 fibers don't have quite the same growth potential that your type 2 fibers have, so they can't get quite as big, takes them longer to do so, and so that's part of the reason that people have a tough time increasing the size of their calves sometimes. So between gastroc and soleus, effectively you've got kind of three heads, right? So because gastroc has two heads, a medial and a lateral, and then soleus has its one origin, but all three of those run together and insert via the Achilles into the calcaneus. And so sometimes those are referred to as the triceps surae. So if you see triceps surae, it's referring to the gastroc and the soleus together. And then the last muscle in the posterior superficial compartment is one that we covered with the knee, and that's our plantaris. So you can see plantaris, as we discussed last time, originates from just above the lateral condyle, more specifically from the lateral supracondylar ridge. It inserts into the calcaneus via its little feathery tendon here, or thin little tendon right there. So you can follow it all the way down. There it inserts into the calcaneus. So again, it is a plantar flexor. So plantar flexion, talocrural, and then it's also a flexor at the knee, so flexion, tibiofemoral in that case. So those are the three muscles of the posterior superficial compartment. Now we'll take those off and we'll go posterior deep. So we've removed gastroc, soleus, and plantaris, and we're on to the last three muscles, our posterior deep muscles. And so the first one is tibialis posterior. And actually, to get to tibialis posterior, also to take off another muscle, flexor digitorum longus, which is our next one. So there's our tibialis posterior muscle right there. So the origin of tibialis posterior is the upper half of the tibial and fibular shafts and the interosseous membrane. It's going to run behind the medial malleolus, run up underneath the foot, and it inserts onto the navicular, all three cuneiforms, and the bases of metatarsals 2 through 4. So it has a couple of actions. Those are plantar flexion, taillow, accrual, and then inversion, subtalar. And just like tibialis anterior, tibialis posterior is going to play an important role in holding up the medial longitudinal arch. So again, the primary arch of the foot. Then we got our flexor, skipped one. So then we got our flexor hallucis longus is right there. So again, anything hallucis is your big toe. So flexor hallucis tells you what it does. So it flexes your big toe. But in addition to that, it's also a plantar flexor and an everter. So the origin for flexor hallucis is the lower 2/3 of the posterior fibula. The insertion is the base of the distal phalanx of the first toe. And so again, in terms of the action, it's plantar flexion, inversion, and then, so plantar flexion is taillow-accrual, inversion subtalar, and then flexion, both at the metatarsophalangeal and of the IP joint of the first. Then lastly, we have our flexor digitorum longus. So it's going to have a tendon that splits into 4, so it'll affect digits 2 through 5. But what flexor digitorum longus does, or its origin, is the middle third of the posterior-medial tibia. And then the insertion is the base of the distal phalanxes of toes 2 through 5. So its actions then are plantar flexion, taillow-accrual, inversion, subtalar, and then flexion, and again on all of digits 2 through 5, MTP, and both IP joints. So flexor digitorum does quite a few things. So the last thing that I've got on there is an expression from a book that we used when I was in grad school for athletic training. That the book itself was published in the 1970s and has a lot of drawings, and all the drawings people have afros. But the expression in the book probably comes from the 1940s, and the expression is Tom, Dick, and Harry. And so what that deals with is the structures just behind the medial malleolus, so just behind your inside ankle bone. So Tom stands for tibialis posterior, the D is for flexor digitorum, AN is artery and nerve, and then Harry is for flexor hallucis. So if you look at the inside of your own ankle, you can find most of these structures. But certainly if you look at the plastic legs, just behind the medial malleolus, you'll see 2 tendons, an artery, a nerve, and then a 3rd tendon. And so the first tendon just behind the medial malleolus is tibialis posterior, then flexor digitorum, an artery and a nerve, and then flexor hallucis. So that's why that's on there and what that stands for. So those are all the bones and muscles for this week. Pretty long lecture. Thanks for sticking with me through all of it, and we'll see you in lab this week, and we'll try to find all that stuff on the models.